First of all, good afternoon and welcome to the village of Oak Brook. As my good friend Dr. Rao indicated, I've been in the area for more than 30 years in the Oak Brook area, but I've known him for close to 40 years. I think we went on a cruise together in Hawaii, if I'm not mistaken. First of all, Oak Brook is a small community. We have about 8,000 people or so at night. In the daytime, we have about 100,000 because we have a huge commercial sector. As you know, the international headquarters of McDonald's is here, and many other large businesses are here as well, and the shopping mall and so on. So even though we are a relatively small and sweet community, we have to be prepared to take care of about 90 to 100,000 people that are here in the daytime. And then when we go to bed, we are down to 8,000. When we wake up, it's again 90 to 100,000. So it's sort of an expanding community in the daytime. So I want to welcome you, and I've heard a little bit about you, Dr. Ramesh, through Leela, as well as every time I go to speak somewhere, I do research the person that I'm going to meet. So I dig deeper, and he's done a tremendous amount of work, obviously, at many of the hospitals that you're associated with as an interventional cardiologist. And today, as you know, the topic is Golden Hour Project, and that's so dear to my heart. I'm a cardiologist, and I'm still practicing, as Dr. Rao correctly stated. And you all know, some of you are doctors here, I know, but many of you may not be. Heart attacks as well as strokes, there is that golden hour during which time things have to be done. Either thrombolytic therapy, the blood thinners, I'm sure you're going to address that, or interventions, angioplasties, and stent. As a matter of fact, where I work, in one of the hospitals at Good Samaritan Hospital, they don't call it golden hour anymore, they call it golden half an hour. You know, immediately the patients are rushed in there to the cath lab, and in some cases we've been able to open up the arteries in about half an hour. I know the situation in India is a little more difficult. People take a long time to figure out whether it's even their heart that is hurting them. They think it's indigestion, particularly in women. You know, the symptoms are atypical, and it takes them a few hours to just figure out that it's the heart that is causing the problems. And then the issue of 911, I don't know how prevalent it is now, but when I used to be training in Bombay, I was at KM Hospital, you know, in the 60s and 70s. There was no concept such as that, where people can be emergently taken over to the cath lab and so on and so forth. There was no concept of pre-hospital thrombolysis, for example, which we do have here, but it was just a difficult situation. From my understanding in India, it still takes most people 3, 4, 5, 6 hours to get to the hospital. And then after that, I believe it takes another hour or two to get things mobilized. And please correct me if I'm wrong, because things may have changed, and I know we are now into the 21st century and even beyond. In many areas of cardiology, India is actually even more advanced than we are. So I'm happy to see you, and I'm happy to listen to whatever new things that you may have to tell us, so that we can all be more aware about what's going on back home in our own country. And I take this moment on behalf of the village of Oak Brook and the residents of Oak Brook to welcome you to Oak Brook, and hopefully this will be one of the first of many, many trips to come. Thank you again.
Basically, I'm an alumnus of Guntur Medical College and All India Institute of Medical Sciences, and I'm very proud to see you, Dr. Ramesh. You also, you are an alumnus of Guntur Medical College and AIMS. I'm very proud to see you here today. My involvement with the resuscitation programs almost dates back to 33 years. And I've been involved with the American Heart Association for the past 30 years. And currently I'm on the international committee of 10 members. We take care of almost 80 countries, but I'm also the liaison for India. And having said that, our active involvement with the Indian system of resuscitation and simulation dates back almost like 12 years. So about 12 years ago, we initiated the process of implementing the BLS, ACLS, the PALS programs, and recently the ACLS EP for the Experienced Providers course. And you know, when I was growing up, like you, at All India Institute of Medical Sciences, the resuscitation was in infancy. So, and I'm very happy and proud to say I go every year, at least once or twice as a visiting professor to various institutes. So when I was giving my lecture at Darwin Institute of Medical Sciences last year, I'm very pleased to say that as Dr. Gopal Malani was alluding to, the amount of transformation that has occurred, the amount of advances that we see in cardiology is on par with what we see, in places like Harvard. And I'm very proud to say that. Having said that, the resuscitation is, as a science, is in infancy, even though it dates back to the Russians, in 14th or 15th century, where they used to bury the half-dead person and put him in an ice box. Since then, the resuscitation has taken so many upgradings, and the American Heart Association, we are very passionate about resuscitation. What you see, the guidelines of the American Heart Association is a product. Every 5 years, we give the products to the various countries of the world. We are involved with almost each and every country, and again, we are involved with 80 countries. The committee is dedicated to the resuscitation programs. We have a multitude of programs like the international training centers, and I'm very proud to say today, we have got 63 American Heart Association international training centers. And we have almost thousands of American Heart Association instructors. And I'm very proud to share this information. Colonel Ashok, he was my student, who is one of your ACE instructors, and he's a faculty there. He is one of my students, and I'm very proud to see that he is making so many sacrifices. He's a true Gandhian, so far as I'm concerned. And I'm also very proud to say, and I see mostly the Telugu people here, we are the first university, Dr. NTR University of Medical Sciences is the first university to mandate the ACLS and BLS courses in the academic curriculum in the entire country. And that happened about 6 years ago when Dr. Ivira was the Vice Chancellor. And today, lo and behold, we get so many requests for the international training centers. And especially, I know a little bit about you before you came here. Dr. Ashok was mentioning about you. You are truly passionate about what you do, and you are truly committed, and you're motivated by some personal tragedy. The stroke and all that stuff. And again, stroke, as well as the myocardial infarction. As Dr. Gopal Malani was saying, they are the silent killers. And unfortunately, the Indian system is totally different from here. And we are talking about 108 programs and all that stuff there. And we are working with several governments, with Andhra Pradesh, with Telangana, and the EMRI. We have got programs. Last year, I started a program with the Indian American Medical Association, the American Association of the Cardiologists of Indian Origin, and several programs are brewing now. And for the first time, we sent about 4 candidates, residents, as a part and parcel of their residency programs to Hyderabad area, and they stayed there for 1 month and gave the demonstrations to the local people, and it becomes a paper now for the American Heart Association sessions. So again, thank you for giving us an opportunity to share the information, and you can look forward to our help from not only the cardiologists, but from anybody that owes something back to India, And so far as the American Heart Association is concerned, you can take it for granted, that anything we can do for you, anything we can do for our country, we'll be very happy to do that. Thanks for giving me this opportunity, and good luck to you in your endeavors.
Good afternoon, everybody. I'm very fortunate to be in this great country and great village. In fact, I have been practicing in Vijayawada, that is Andhra Pradesh, for the past 3 decades. To start with, it was a non-invasive cardiology setup because that time Vijayawada, the place was where I was educated. The cardiology, I had to start the first ICCU, and then after 8-9 years, I started a first cardiac cath lab in 1996. But since in the past 3 decades, as you have rightly mentioned, golden hour, there was a lot of delay in identifying as the problem whenever a person has got chest pain, saying that it's gastric trouble, and then the local doctors, registered medical practitioners, and by the time they come to the hospital, almost a good number of them are having massive damage. And the same thing continues, like even now, after 30 years, let us say maybe about, there is some 10-20% change over and above what it was. It is largely because of the silent attacks or perception of the patient, even perception of the physicians. So, in fact, in 1997, I thought I should educate. Sitting in a hospital doing angiograms, angioplasties is much easier. But then trying to educate the whole lot of people is much more important. So what I did was I started printing some matter in a pamphlet form mentioning that Modati Ganta Amulyam. That was my first in 1996. So that means golden hour. That exactly means golden hour. So then we started distributing in the patients, and then several camps which we conducted, the golden hour, the pamphlets. And then we started installing the computerized ECG machines in the mandals and villages where, in the periphery, where there's no one available to make a diagnosis, whether it is a cardiac or non-cardiac chest pain, especially in the evening times and nights. So that we have done, and then several thousand ECGs were done. We found that it is very helpful. And after that, in 2010, we started an education society, Health and Education Society, in the name of Ramesh Health and Education Society. And we started doing some more activities, focusing more on telemedicine. Because we understood that apart from having creating an awareness and having accessibility to advanced healthcare, it is the right time, and then telemedicine is the only way to have a connectivity with the patients. And in the peripheries, we have started around 13 telemedicine centers. But that time it was very, very difficult when we started. There was no fiber grid as we have now in Andhra Pradesh. And we had to obtain special permission from BSNL. We used to spend a lot of money. So now after that, in the past 2 years, when we had a meeting, Mr. Lakshminarayan Garu and Sarthi Garu, so we started going around several places, medical colleges, engineering colleges, and then this Golden Hour project, creating awareness amongst the general public. So, but in the past few months, there was a slight delay. So that is how Sarthi Garu said, we should do something. The pace is slowed down. We should do something. You're coming to Milwaukee, anyhow, my sister's place. Why don't you? This was hardly about 10 days ago. But then the way, they have responded, I thought it may be very difficult. But then he said, okay, we'll try to do something here. So, the beginning and program is very, very encouraging to us. And in the next few slides, I'll just try to focus upon, most of you must be knowing what is Golden Hour, and then the telemedicine services which are available here. And off late, with the existing shortage of infrastructure and human resources, it is the Golden Hour, creating awareness about the Golden Hour, providing accessibility, strengthening the primary care health centers, and connecting them through telemedicine is the way to improve the outcomes in regards to mortality or morbidity, and also the cost-effective delivery of the healthcare system. Fortunately, in Andhra Pradesh now, with the dynamic Chandrababu Naidu CM, and then the nation, you have Modi government, that they seem to be taking a great interest in the Niti Aayog. Now, they are also trying to connect the whole country through telemedicine network, which I'll be just sharing whatever we have there. So the other idea of trying to meet is what we have experienced in this Golden Hour project, or in the 4 or 5 districts of patient population which we have. The peripheries, those 60%, 70% of the people live in villages and mandals, they are terribly, they are afraid that after 6 or 7 p.m. there is no doctor available, and because of the problems which they face, sometimes if they lose a patient, nowadays you must be seeing in India the doctors are being sometimes bashed and all. So many people don't open the doors in the night time. So say after 6 p.m. Till next day morning, if somebody has got a problem in mandals or villages, they don't have a doctor. So for the whole answer will be definitely the telemedicine and the ability to provide or connect the primary care centers to the tertiary care.
Sir, I have a question. I recently lost one of my uncle. He walks every day in the morning 4 kilometers, evening 4 kilometers, eats on time and sleeps on time. But the reason for the loss of him is calcium formation in the valves. which we have, I mean, I haven't heard. First time maybe I heard somebody has calcium in the knee or somewhere,
Right.
but not in the heart.
Yeah.
Is it a thing which is already there, or the doctors doesn't know, or?
Very important question, which in fact is my passionate subject. Nowadays, see, the whole 40-50 years in the past, the whole community, medical community has been talking about changing the lifestyle, eat this, eat that, and then do exercise, and this will prevent your heart attack, which is not correct. Absolutely, it is found to be wrong, because now, if you see in our acute intensive care unit patients who are admitted with acute heart attack, more than 50% of them have no risk factors or so-called low risk category, which we call. See, when we sit in the OPD, a person with 55-year-old comes and then says, "Check, doctor, check how is my heart?" Then we say, "Oh, blood pressure is normal, you don't have sugar, you don't have diabetes, you don't have cholesterol, high cholesterol, you don't have family history, fine, you won't have." But then that is wrong. Now, 50% of the people admitted with heart attack are in the low risk group. Now, what we have is so-called calcium score and CT coronary angiogram and CT FFR, which is likely to come up. So now this calcium score is one of the most important parameters now. I mean, Dr. Gopal is here. I think he would agree with me. Well, you see, the calcium score and CT coronary angiogram, if you have in a 50-year-old person, it is no plaques, no calcium. It is a 15-year warranty test. In JARC, April 2015, there was an article published wherein they have followed almost for 15 years, 9,000 odd patients, and they have found that less than 1% chance. So if you say that 99% chance that you will not have a heart attack in the next 15 years for a 50-year-old male, that's a tremendous news for him. Because when anybody asks, then we say, okay, you control the blood pressure, you walk and all, but then we never give that warranty. Now they have mentioned in the article name itself, warranty against heart attack.
So there are a lot of things.
Yes.
Calcium score, a lot of hospitals and some of our own group, and we're doing it like as a campaign for $50 or whatever, 100 as a just like your fair, health fair kind of thing. Yeah, when you do that, a lot of people come and do it, and just like when you do a regular new office visit, on top of that you pay $50 or anything. Yeah, because there is no recurrent die or anything. Anybody can walk in and get it done, go away.